Before I get started, I'd like to thank all of the A&N people, all the names that you've heard throughout the days, especially Rick and Mona and Mike and Joe. The workshop was unbelievable, the research workshop. We don't get to talk to each other about this group of diseases very often. Even if I can get an audience of my colleagues in the eye care profession, either on the ophthalmic side or the optometric side together in general conferences, as soon as before I even get the last syllable of nystagmus out, they usually leave the room. The students that I try and teach about nystagmus usually the only question is, what do I need to know for the boards? And then after that, they've completely forgotten about it. So it really is orphaned at all levels, not only from the clinical level, but the educational level, the scientific level, the funded level. So I know from you and from my own perspective, the sense of abandonment of the community about a particular problem that's so meaningful to everybody here. And so I really appreciate and feel connected to this organization and to all of the people that have come here and the people that have taken the time and the energy and to come and see me and follow me around on all my travels around the country and spend time with me. So after thanking them, I think that I don't have a presentation because I thought a lot about this, and I think anything that I was going to say formally or present is available. I mean, a couple clicks away. I'd rather make this about you. You're the ones that came here. You're the ones that came for information. I feel like if you could come and visit me and sit with me privately and ask me what you wanted to ask me, you have the opportunity to do that. In preparation for that, I would like to pretend that maybe you're sitting in front of me in the office, and some of you have done this, and that I'm going to give you my talk. I may have prefaced it that way with you. Here's my nystagmus talk. Say you're a patient or you have a child that's a patient, and we talk about the visual system of nystagmus. And I assume when I see families that not everyone is as educated as the group here, and that I'm talking to a completely naive audience. So I'd like to start with that again, and please bear with me if I sound redundant. But I'll do this for 5 or 10 minutes or so. Once I start seeing the first person nod off and the head goes in the same direction as the eyes. And nystagmus comes from to nod, which is, nice. And then for the rest of the time, however, until you are finished asking me questions, I'll stay up here and answer whatever I can for you. And I thought that would be a better way of spending my time than another conference room with PowerPoint, which many of you have been in too much. So I'll begin with the visual system. So the visual system is probably the most complicated sensory system we have in the body. I think the thing that separates humans from all the other animals on the planet is speech. Speech is what makes us, I think, the most human, because it conveys a way to connect for each other, a way to build each other. And the neurological system and the development, if you look at the embryology of the speech system, the phylogeny of the speech system through creatures that crawl and communicate with each other that way through us, it's the most complicated neurological system from a brain point of view, a neuromotor system. It's more complicated than being able to write or use our hands on the keyboard. The second most complicated system is actually the visual system, because it combines two very complex parts. It combines the ability to see, the ability to take the world, bring it in, and have a sense of vision, like a sense of smell. But it also works cooperatively with a silent partner. And the silent partner is the ability to move the eyes, not just move the eye, but move the eyes. There is no other system in the body, no other paired organ system in the body, the lungs, the kidneys, that work together like the two eyes. That neuromotor system is as complicated, probably if not slightly more, it depends on which side of the science fence you're on, as speech, to be able to use both eyes together. That neuromotor system in the brain, the human brain is probably the most complex thing in the universe. Trillions of connections working all the time. And the more we learn about it, the less we know about it and how it starts to work. And our thinking about how it works now has changed so much from, here's a lesion, now I can't speak. It's how the brain we're looking at now like a big internet system. So the visual system has these two component parts, the ability to see and the ability to move the eyes. They don't operate independently, even though they're both extremely complex. It'd be like all of the people in New York City and all of the people in LA communicating with each other all the time and be able to coordinate their days, every person all the time. That's how complicated the development of this system is. So I'm given these anatomic pathways to see so that I can sense the world. And I'm given these anatomic pathways at birth. And if I'm fortunate, I'm given them correctly. I'm given the right anatomy, the paved road is done, the curbs are put in place. Everything's set for us to go, to travel. So I have these two pathways, but what really is taking place is the communication between them two. So the developing ability to see and the developing ability to move the eyes are also talking to each other while they're being built. It's this communication between the two systems that gets disrupted in most of the problems that you all have as patients or your children or your family members have that result in this oscillation. So in the end, whether the perturbation of the system itself is because the ability to see was messed with, a retinal disease, optic nerve disease, a disease of the cornea or the lens in a new baby, or the developing motor system was messed with, maybe in some forms of albinism, in the genetic diseases that Jay and people like himself have discovered called FRMD7 genes, where maybe the motor system is primarily involved. But these perturbations in the two systems interrupt communication. This communicative system now is broken. And it's not just breaking the system, it's breaking the system in the first few months of life when it's critical that it's not broken. If I introduce the same perturbation in the system of a 6-month-old baby as a 2-month-old baby, I will not get nystagmus. So it's crucial, it's a timing thing. It's a very unusual disease. It's like amblyopia or lazy eye in ophthalmology. It's another visual system problem that can only occur during a critical period of human development. So nystagmus can only occur during a critical period of human development when the right set of circumstances occur. So it seems odd that it would occur in so many people, and it's one of the reasons it's rare. But it does happen quite a bit for multiple different reasons. So the final common pathway in everyone is a perturbation in the developing communication between the ability to see and the ability to move the eyes. That's the big picture thing. So now the baby, the child, is born, and the entire visual system is disrupted. It appears as though it's just the eyes that are wiggling, and that's the problem, because that's the most obvious thing that we see, that you see, that I see, the eyes are wiggling. That's the name of the disease. But the entire visual system is affected, and vision is more than what we think of when you go to see an eye care professional. It's not black letters on a white screen in an eye office. If it was that, then the whole world would look like a 1940s Mickey Mouse cartoon. And that's not how the world looks. The world is full of color, it's full of motion, it's full of depth. The world is the richness of all of the color, the richness of the world. Every part of that is affected by nystagmus and the other effects of the visual system. So when I say that, and the reason I say all this is because I feel that my responsibility, not as the science part of myself, but the clinician part of myself, is to recommend treatments for the visual system, Part of that includes treatment for the nystagmus itself. But since the entire visual system is affected, then maybe we need to treat the entire visual system. So if we can understand all of the parts of the visual system that seem to be affected by this and break them down and understand them, and that's what we in the science community do, then we can help that part and then build up the visual system again. For instance, if I have a child who's born with a retinal disease and nystagmus, if I can make the retina better and stop the nystagmus, the child would do much better than if I could do one or both. If I have a child who's born with congenital cataracts and has nystagmus, sometimes if you take the cataracts out early enough, the nystagmus actually goes away and is treated because you've treated it during that critical period itself. So it's important to us as clinicians to treat the entire visual system, and to understand the entire visual system, you have to undergo a complete evaluation, not just eye movement recordings, but everything else. And those of you who have been to my office have had this done, and when you go to one of the centers of one of the scientists that you've seen here today, you get everything done: optical coherence tomography, OCTs, visual fields, visually evoked potentials, color vision testing, electroretinograms, and standard eye exam in addition to all that, because then we test the entire afferent and efferent systems, and then we can tell uniquely where your or your child's visual system is at that point in time and what the anomalies are. Say the child has a congenital color vision deficit because the cones are not working as well. There's not a lot we can do about that. So no matter what we do for the vestibular system, it's important that you know that your child's not going to see colors the same way. Whatever way they see them, we have to characterize that so that they understand that, you understand that, the school understands that, so he's not sent home because he's not recognizing the colors properly on a school test. So these are just as important to me as on the clinical side as doing something about the nystagmus. So having said that and saying my goal is to make the visual system better, what's available in 2015, today? And what's available to me or to the other clinicians and scientists who are in this room is available all around the world, but not necessarily chosen by the rest of the world. Unfortunately, it's a comet effect. The application of new theories, ideas, and technology in medicine has a comet effect. So you have the comet and you have the tail, and the tail can be sometimes light years behind the comet. And so it takes a generation or two for things to get accepted as standard of care. Whether they're dangerous or not, that's not the issue. It takes a while for things to evolve and go through the educational system because people are comfortable at what they're doing. But I'm going to share with you what I think is available in 2015. And I break it up into three things: medical treatment, optical treatment, surgical treatment, and for lack of a better term, non-traditional treatments of the visual system. So medical treatments include things like oral medications, and now we're investigating topical drop medications, and these work primarily on the neural system to try and reduce the nystagmus itself. Optical treatments are simple but powerful things like glasses. Now everyone says, what do you mean? Well, you know how many patients I've seen who haven't even been given glasses and told their child was blind, and they had 8 diopters of cylinder, astigmatism, and that would make your vision better by 5 lines. Contact lenses are extremely powerful functionally, and in some patient populations, they may benefit the oscillation itself. Other optical treatments include low vision devices. Particularly important are computer-assisted instructions, computer-assisted devices. Now with the tablet technology, iPad technology, I have no interest in any of those. You can use those in the classroom to make the child not stand out and do as well because they can bring distance information up close. So these are very powerful treatments. And the last are surgical treatments, which I'll spend a little more time on. So in any one patient, the combinations of medical, optical, and surgical treatments would be very helpful. The last thing is non-traditional treatment, and the only one that I've suggested to my patients, and some of them, I have, I think 12 now, 11 or 12 that have completed some of the program. John Kabat-Zinn is a very famous psychology MD who was, I think he's maybe still at UMass Worcester, or he's in California. He may have just switched over, but he introduced mindfulness meditation into modern medicine for use in cancer, in arthritis, in hospice care, and this technique seems to help in many types of chronic diseases, even certain forms of mental illness like chronic depression and bipolar disorder. So I have some patients who have taken the full 12-week John Kabat-Zinn course in mindfulness meditation and are able to control their nystagmus to some degree and at least minimize their nystagmus in stressful situations like taking their driver's test or their first date or something. So that's the non-traditional one that I think really we need to, and Larry's particularly interested in mental state and its effect on the nystagmus. And those of us that study it are interested in it because if I'm doing a study and you're nervous pre-op and you're not nervous post-op, maybe the reason you're better post-op is because you're not nervous anymore, right? It has nothing to do with the surgery. It has to do with your anxiety level. So it's important that we try and control some of these things as well. So that's kind of my global talk with this, and now I'll specifically talk about surgery. And surgery on the eye, surgery particularly for nystagmus is surgery on the eye muscles themselves, not on the lens or the retina or any other place for nystagmus. And surgery on the eye muscles has been done fairly routinely for over 50 years. The most common indication is for a persistent, this is the common standard of care worldwide indication for a persistent unidirectional, anomalous head posture later in childhood. That's 8, 9, 10, 11 years of age. And so the amount of children that actually meet that criteria is very few of the ones who have nystagmus. So there's not a lot of that surgery performed. It was initially performed by a guy named J.R. Anderson in the mid to late 50s, and then immediately followed by a guy named Kestenbaum and a Japanese person named Goto in Japan, who kind of modified the surgery. And in the late 70s and early 80s, Lou DeLoso, Larry and my mentor, you know Lou, and John Flynn, who was the ophthalmologist he worked with in Florida, discovered that not only did the head posture straighten, but the nystagmus got better. And they wanted to figure this out. So we discovered some animal models in the 90s and did some research showing there was something about actually operating on the eye muscles themselves, just actually cutting the muscle that made the nystagmus better. As a result now of 15 years of research and thousands of patients in animal studies, it turns out that we're actually probably interfering with some neurological feedback loop at the time that we do the surgery, and we're recalibrating the brain a little bit in the sense of a thermostatic control. So part of the surgery, the goals of the surgery used to be just to straighten the head. The goals of eye muscle surgery now are to straighten the head if there's a head posture, straighten the eyes if the eyes are not aligned, and also improve the nystagmus. And it's that third goal that's increased the indication for eye muscle surgery. So those are the three goals of eye muscle surgery. Not everyone who I see are those three goals amenable. There are some patients whose nystagmus is so minimal and their null position is straight ahead that even doing surgery is not going to make it much better. There are very few of those, believe it or not, probably only less than 5% of the patients that I see. But there are few. There's a lot of patients that have eccentric null zones that haven't used them because most patients, most children, will choose to sacrifice their vision rather than their neck. If you do this yourself, if you're sitting there watching me and you all turn your head 30 degrees to the left and try and look at me and keep a stopwatch and see how long you can do that, I bet most of you won't be able to do that for more than 30 seconds without turning your head. So now you have to sacrifice, do I see or do I feel good? Do I see or do I feel good? And most kids, except for a few exceptional kids I have, will choose to feel good and not see. So they will give up their head position, and the clinicians say, the head posture went away. But they don't record eye movements and see that the null position is still there. It never goes away. And they just stop using it. And this is especially true in albinism with chin down, chin up postures. So undiagnosed eccentric null positions are very common in clinical conditions where eye movements are not recorded or the patient's not examined very thoroughly. So those are the three goals of eye muscle surgery and what we do. The procedures themselves are standard outpatient procedures. The procedure is not new. It's not. This is kind of an ideal situation from a surgical perspective in that we're not describing a new surgical technique. We're just expanding the indications for a surgical technique that's been going on for 160 years. Most of this type of eye muscle surgery is done for strabismus or lazy eye, either in adults or children when the eyes don't work together. So those of us who do this, mostly pediatric ophthalmologists and adult strabismus surgeons, some neuro-ophthalmologists, around the world, general ophthalmologists will do this more than the United States and Canada because there's less specialization. So this technique has been around for 160 years, modified very little, really improved mostly by anesthetic, postoperative pain management, and suture materials. But the techniques themselves are pretty much the same. If you look at a textbook from 1898 and how to do a muscle recession to now, there's very little difference. So it's not a new operation. These are not new operations. This is just the expanded operation. There are some tinkering that's been done with eye muscle surgery to help eye positioning. And I have, as a result of operating on thousands of patients, I've kind of classified and categorized the most common operations. And I have a classification scheme that numbers them 1 to 9 based on the amount of operations that I do for that nystagmus. And it just groups the muscles together. It's an algorithm to assist clinicians to help patients with nystagmus without having to do a big workup. One of my challenges was how can I assist patients and other doctors without having them go through the entire process that we go through to understand this. And so I give them a black box algorithm to help patients with nystagmus. This is published in articles and also reproduced in Lou and mine's textbook on infantile nystagmus, which came out last year, I think, by Oxford University Press. So that's the indications. What can happen with surgery? Well, The worst thing that can happen when you get operated on is that you can lose the organ or lose your life. And that happens with any operation. The chance of that's probably about 1 in 20,000. It's the lightning strike. Actually, the true numbers risk is getting in your car and strapping your child in the car seat has the same risk driving on the freeway as something serious happening in surgery. Having said that, 5% of patients that I operate on have something unexpected happen that's easily diagnosable, reversible, and treatable. The list is about 100 long. Could be a small suture reaction, a cyst, a superficial infection, the muscle slips, but all of these things are kind of the cost of doing business when you operate. And it doesn't reflect on the skill of the surgeon, the cooperation of the patient, how good the anesthesia was, what day of the week it was, what sign is up in the sky. It's just, if you don't have complications and we don't have problems, we're not operating. When I ask a surgeon, they said, I never have a complication. I go, well, you must never operate, you know? So my mentors in surgery, in the actual cutting and sewing department, were always the women and men who are really good at handling something that went wrong, either intraoperatively or postoperatively. Those were my heroes. How did they do that? How did they deal with the families? And how did they deal with the problems? And there are problems, and I recognize that, but most of them we can solve and treat together. The important thing is that we have a good relationship so that if there's a problem, we can deal with it together. Because I understand that most of the time it's not you as adults, although 20% of the time it is. Most of the time it's, here's my child, stick a knife in their eye. Oh, thanks, sure. You know, so that it's not an easy thing, I understand, as a parent. So you want to have a little bit of trust when you say goodbye that this person is going to do a good job. So I think that's my surgical speech very quickly. And I am happy to talk about anything you want to ask me and answer your questions. And I'll leave it, make this your conference, because this is your conference. This shouldn't be about me.
Do you have any kind of percentages, and you know, not exact figures, but for all the surgeries that you've done, the percentage of people it helped, the percentage it had really nominal or no effect, and then the percentage of people who actually got worse? Because I've seen reports of like ongoing double vision and various things like that. Is it? I'm just. You know,
so it depends on how you define success, right?
Yep.
So the goal of surgery is to improve the eye position, improve the head position, and improve the nystagmus. Those are the 3 goals of surgery. This is a speech I give to everyone. Making the nystagmus better, I haven't ever recorded anybody that the nystagmus has gotten worse on, ever. That's never happened. Moving the eye position, I can always move the eye position. Do I move the eye position and it's not in the place I hoped it would be and I have to move it again? 15% of the time. The head position, do I move the head position and it's not exactly where I want it to be, or do I have to move it again? 15% of the time. So does that answer the question?
Yeah.
And double vision, the chance of having double vision is 100%. Every patient wakes up with a little bit of double, even the kids. Almost all of it, about 95 to 98%, goes away on its own. In those patients who come in with double vision, they present with double vision, the chance of curing double vision is very small. The chance of a patient who comes in with double vision, who we create double vision from surgery, we can always make it go away because I can put the eyes back where they were. And that's the key with that. So if a person comes in and says, I need my double taken care of, I go, well, I'll do the best I can, because single vision is not in the eye muscles. Single vision is in the brain. And so if I can take the eyes, and even with adjustable suture, and align them parallel, if the brain doesn't use them together, then they're going to have double. Are there irreparable chances where, yes, there's situations where you can operate, the muscle can slip completely and lose? That's the 1 in 10,000 thing. Yes. Right. So I think, for me, I don't recommend surgery unless I think the benefit-risk ratio is high enough to do it. But you have to have, as a patient, what success means in your mind, not my mind, right? So you have to be clear about what success is to you before you say, yes, I want to be operated on. I think.
Could you comment further, please, on that part about stress, fatigue, and eye movement, the role that that plays in nystagmus, and visual acuity?
Yeah, so visual, you mean visual acuity, you mean my black letters on a white screen stuff. That's what we mean by visual acuity on the science side. So black letters on a white screen is a very transient phenomenon in all patients with nystagmus. Here's the unique thing about patients with nystagmus is they have a dynamic visual system. Patients with nystagmus never have the same vision from moment to moment, ever. We have a static visual system. So imagine a nystagmus patient has vision like we smell. You know, I can walk in, my wife's cooking dinner when I get home and it smells great. I'm in the same kitchen 5 minutes later, I don't smell anything anymore, right? And so imagine your vision changes like that. You know, it gets better, worse, better, worse, better, worse, all the time, because your visual system's changing all the time. So visual acuity is not static. It's not a static process. And so you can change that based on how strong. You know, if my wife left and went out and was taking care of the dogs and the food was left on the stove, I'd smell it for a half hour instead of 5 minutes, right? So stress, fatigue, illness, sedation, some medications will make the nystagmus worse and change and make the vision fluctuate more. And each person has their own idiosyncratic reaction to that. So the patients tell me more about that than I do them. And the way that I learn about this is from you all. I say, well, what happens when you get anxious? What happens when you get nervous? Well, I don't see as well, or they don't, you know. That's how we learned about this, from you. Does that make sense? Laura?
2 questions. The OCT machine, do you have that?
Yes.
Okay. The other one is
The OCT machine.
the OCT machine. Second question is, the year I saw you, somebody asked me about my head turn after I got, if I were to elect to have surgery. What do you see in patients in the follow-ups? Do you see that they have issues with now that they don't have a head turn?
So-
Are there like psychosomatic, psychological
Oh, yeah.
issues without having a head turn?
We're trying to find that out. Rebecca's working with us on developing an accurate questionnaire to try and understand the impact that this type of surgery has on all aspects of self-esteem, confidence, and awareness. I can tell you that my experience is 2 things. If a patient has a head oscillation, it's different than a head posture. So as you know, you can do this and also this. In older children and adult, there seems to be a habitual posturing that may be wired, or there may actually be some changes in the neck muscles, which is one of the reasons I like to get to the kids early. Because I think after 10, 12, 15 years of age, then there's probably some neurological hardwiring about where is the center of the body and the head. And even if you take a child or an adult, if I take an adult who's had a head posture their whole life and I turn their head straight, they say it's crooked.
It
So-
does, it feels crooked.
Right.
It really does.
Yeah, and that's called egocentric localization. And your egocentric localization is off. It's off. And I think that happens in the first decade. So we want to reset that point, because then the head posture will return, not because of the nystagmus or the surgery's not working. It's because your body set point is over there.
That's what I was curious about, because it does. I mean, if I try to, turn my head feels normal. It's normal. But if I try to straighten it, it's just like, I feel crooked.
Yeah, that's the result of how the balance mechanism, the vestibular system, works with our body and space and gravity and the intricacies. The head oscillation is a little different. I mean, that's a hard thing to treat. Eye muscle surgery, there's some medications that seem to help that. That can be controlled individually amazingly well, the head oscillation itself. And we have a protocol in place where we're starting to think about putting Botox in the very small suboccipital triangle muscles, these very tiny muscles that are responsible for the small rotational head movements that you see in infantile nystagmus, as well as in Parkinson's and some forms of dementia as well. So I'm working with a dystonia person at Children's Hospital, and we've done the anatomic studies, the feasibility studies, so we're getting ready to kind of roll that out pretty soon. Yes?
Okay, you talked about oral and the drops.
Mhm.
Okay, what does that do? Because you talk about cutting the nerves and what, the head, so everything. So what will the oral drops do?
So oral medications are generally used to affect areas that we think may be controlling the nystagmus in the brain. The best way to do that is the same reason that you would use oral medications for seizure disorders, for mental illness, for sleep problems that work on areas of the brain. There's medications that overlap with helping nystagmus too. There's a list of about 8 or 10 that I'll use, and there's a top 2 or 3 depending upon whether you're an adult or a child, or you have acquired or And so these medications act on the brain itself, like a seizure medicine.
Will it lessen the eye movement, or what's?
So the goals of all these treatments are to improve the nystagmus, and in some cases, it makes the cosmetic appearance less, but in many patients, it actually makes the beat-to-beat change better. So what's happening during each beat of nystagmus is your brain is essentially taking a snapshot of the world. If I can make that snapshot longer during each beat, then you'll see better. But to the naked eye, it looks you still see the oscillation.
Okay, will that have any effect on the eye chart?
Yeah, that's always the question, right? I can't get anything published without putting visually, but the eye movement system was not made to see black letters on a white screen. That's not its purpose.
We didn't evolve that way.
Even though society makes you do that. So it's hard for us to go against nature and say, I'm going to make your letters better. Having said that, I can tell you that treating nystagmus, 75% of patients across the board, more in children than adults, more with lower vision, 75% of patients will get 1 to 3 lines better if you treat the nystagmus. And it's true. I mean, it's pretty consistent. 25% will get no more lines on the chart, but they will get better visual function. The other things I check are contrast sensitivity, motion detection. We've done visual recognition time. And all of these things get better, which is why patients say, I see better, but they don't see more letters. Yes?
How many people have you treated like that are like in families, and do they have the same type of nystagmus?
Yeah, families are a very common form of treatment. And there is a tendency for a genetic, in families, especially the FRMD7s, for actually even the waveforms to be the same. But in families of albinism, it's not exactly the same. So it depends on what else is going on in the family. Yes?
You mentioned the medication, but as far as the drops, I know that's something that was being developed. Is it available yet? What will be?
Yeah, I'll tell you the drop story. Yeah, the drop story is a great story, though, and it actually is some of you may have heard it. It's really an outcropping from this meeting in D.C., I think. So there's three brothers who have nystagmus, family members, FRMD7, great guys. Some of you may know them, some don't. They're all three of them my patients. They all live in different parts of the country. I think we were in D.C., and MJ, I won't say his name because he didn't say I could say his name at the meeting. But MJ said, I think it was like the social thing. It was about 4 o'clock or 5 o'clock. And he said, Rich, I have something to tell you later. And I go, okay. He goes, no, it's really important. I go, you can tell me now. He goes, no, I'll tell you later. I go, okay. This is the way these guys are. So the three of them are like sneaking around, not letting me near them the whole night. And so I'm getting ready to go home. Gloria and I were getting ready to leave. It was like not 10 o'clock. We stayed for the social hour, and MJ comes up and he goes, okay, Rich, now I want to tell you. I go, ah. So I go, okay. So we sit down at the table, and he tells me he was working on his farm, and he accidentally got something in his eye. And he was freaked out, and I go, oh, man, that's what you waited to tell me? I'm sorry. Did you wash it out, you know? And so he goes, yeah, I washed it out. And, I washed it out, and I could see better. And I go, really? He goes, yeah. And he goes, I looked, and I go, I think my nystagmus was better. So I went to see my ophthalmologist, and he said, yeah, your nystagmus is better. So the conference was about 2 months after he got this in his eye. So I go, really? What was the name of it? So he told me the name of it. And the next morning, it was, one of these sessions the next morning. And he comes up to me and goes, did you get any sleep last night? And I go, no. So he knew I was going to stay up all night trying to figure this out, That's why he waited till 10 o'clock. So I brought him back to the lab, and I recorded him, and his nystagmus was out. It was better. So now it's 9 years later, and we're getting ready to do the human trial with this. I've done some animal trials, and we've adopted one dog, and MJ has the other dog we did the trials with. These are animals I've worked with that have nystagmus. And so we're getting ready to start the human trial probably in the fall. During that period of time, we also discovered that another group of medications may reduce the nystagmus that serendipitously a patient was taking orally, called acetazolamide or Diamox, and the nystagmus went down. And I go, well, that medicine is available in eye drop form for glaucoma. So we did a big trial where we had 5 patients have the Diamox drops. It's called brinzolamide. And then they had a washout and it was a pretty good crossover trial. And that was recently published in the British Journal of Ophthalmology. And that seems to work as well. So I have probably about 25 or 30 patients on brinzolamide now. And I haven't done really intense studies with the brinzolamide because I've been concentrating on the other drop. But half the patients that have given the brinzolamide to have stayed on it and have shown improvements. So it seems in some patients, like there's nothing for everybody, but there's something for somebody. But the azopt or the brinzolamide seems to have some effect. So I think there's a way to attack these nerves that we cut. They're right on the surface. Instead of cutting them, deliver a drop to the nerves to signal to the brain, rather than, so it may even save patients, some patients, surgery completely, or maybe less surgery, or surgery plus, I have no idea. But the idea now of attacking this with topical medication without the systemic side effects is very exciting. So, but the work is slow, you know. For 9 years, what I've been doing is paperwork. You know, getting FDA approval, getting patent rights, developing safety and toxicity profiles, and getting funding. You know, it's really, and no one wants to do this. We're doing it ourselves, you know. We're just plugging away, and if it works, then maybe Big Pharma will take it. Yes?
Hi, Rich, how you doing?
Hey.
It's been a while.
Yeah.
In the last 10 years, have you gotten any more acceptance from your community as far as the type of surgeries you've been doing?
Younger, yes. Colleagues and older, no. So it's still I call it a flat world thinking. A famous historian once told me that the reason the Earth's no longer flat is because all the people that believe that are dead. Yes, sir.
I have a question. After the surgery, okay, I'm from Germany, so my English is not so well, but with the nystagmus, I'm suffering with nystagmus, you have this suppression of movement. The people who have the nystagmus know this, looking for a cursor, they don't find it. Well, but I think this is made by the brain, and after the surgery, will this suppression of movement vanish too?
No, I think if anything, that kind of visual inadequacy of finding the cursor, that's one of the dysfunctions of having nystagmus. That particular behavior gets better because that's motion processing, that's visual recognition time, that's eccentric detection of eccentric fixing objects. So slowing the eyes down, it's interesting, if you take a patient like one of you with infantile nystagmus, and I image, we've done this with nystagmus patients, we've done everything to Lou. Lou has had everything done to him, pretty much, Lou Deloso. So we took images of the world and stabilized on his retina as his eye moved, so that he was seeing the world like us, you know, with the world stationary. And the initial response was he got oscillopsia, the world started shaking. That only lasted a while and then it goes away. So I have never had a bad visual effect from making the nystagmus better or slowing it, for lack of a better word. Hasn't made it harder for anybody to do anything. I've had many patients say, you know what, it's better, but I don't feel that much better. And I don't know what that is either. You know, not everyone has the subjective sense of improvement.
No, I mean, I think there is a barrier which is a kind of learning process from the mind to say the world is moving or not moving around. So if I can't see leaves very in a light wind. But when the wind is a little bit stronger, I think the barrier is reached that the mind says, oh, the leaves are moving.
Yeah, that threshold of motion processing is lower. The psychophysicists have studied that. That threshold becomes different when you slow the eye down, absolutely.
So you say the mind will accept?
Yeah. Actually, it's interesting you brought that example up. That's one of the things the kids will say is, I can see the leaves now. I can make details out. It's interesting you talked about leaves, you know? Yeah, Mickey.
If anybody was considering surgery, my niece had surgery with Dr. Hertle, and especially improved her field of vision. I remember she said things look bigger. I think she just meant her field of vision was bigger, her eyes moved less, of course. And a recent thing in
Yes, ma'am.
Will you do an initial consultation on adults?
Sure. 20% of the patients that I see are adults.
Okay, and the second question is there sort of a process, a protocol that you go about to get an appointment with you?
Yeah, my staff has worked that out really well, and they've kept it a secret from me, so I won't mess with it. Yeah, they're really good at it. Yes, sir.
What doses are you using for Vapor?
I'm sorry?
What doses are you using?
3 times a day. 1 drop each eye, 3 times a day.
Have you seen any significant detrimental side effects from the drops yet?
No, they sting a little bit. I mean, no more than it's used in the original trials for the glaucoma. And the pressure comes down about 20%, but in a normal eye, so what? It goes from 11 to 9 or 10 or something. It's not a problem. Yes, sir.
In the non-traditional category, there have been some reports, I understand, about acupuncture being a useful technique. Could you comment?
Yeah, it is useful. The problem is driving around with the needles in your face, right? Although some horror movies, I've seen that happen. Go ahead, Larry.
We published, I think, the only English language study of that when I was at Indiana University, and it was only 6 patients, and it wasn't a blinded trial. But 4 of the needles were in the neck muscles, sternocleidomastoid. And it was developed by Satoshi Ishikawa in Japan. Well, was he in Japan? But it had some beneficial effects in 4 of the patients. In one gentleman, it stopped his nystagmus for up to 2 weeks, but he had an unusual history, and as far as I know, it's never been replicated properly. You'd really need to do it with a sham trial, because questions about stress, for instance, or expectation, they knew they were getting needles stuck in their neck. It's sort of hard to disguise that. And so whether that played a role in the benefit is hard to know. It would be nice to actually see somebody support a trial like that, but to do it properly requires an interesting combination of skills.
Probably acupressure. There are commercial acupressure devices could be used really nicely in a clinical trial, where you could turn them on and off or not use them, which are not acupuncture, but they're worn around the neck or the forehead. They're now used for headache treatments and stuff, you know.
So do you have to leave the needles in?
Yeah, you do, probably.
The needles were in for, I think, 15 minutes.
Yeah.
They got twirled and then taken out.
Yes, ma'am.
For initial consultation, we're in South Carolina, and I have a 10-year-old granddaughter, her daughter. How long of a time period is there to wait for that, if we were to call?
Well, if you ask me, I'll see you tomorrow. But again, I have my staff says don't say anything to anybody. Yeah, some of the other patients could probably tell you.
Really long, like months and months? Or?
No, I think usually within a few months we can get it.
I will say that she had surgery with Dr. Hertle, not this past May, but the year before. I believe I called around March, and we saw him in like April, and then she had surgery in May. So it wasn't.
I do have slots. You know, I see 15 to 20 nystagmus patients a week, so I have slots every week for patients who come in from out of town for consultation, and then there's slots for patients who are coming back who may want more treatment for a 2 or 3 day visit. So we keep those kind of guarded for people who want to come in.
So, you know, Emma has not had any, like an OCT or anything, you know, the ophthalmologist, which is, you know, the best in our area, is she has nystagmus, that's it. There's
Yeah.
nothing we can do.
I'm sure other people have heard that story. Well, I'm glad you're here. I'm glad for Emma's sake that you're here. Yeah.
Rich, you have about 2 more minutes.
Okay. Yes, sir.
The part where you said that some patients can actually choose the area center versus they were in also. Does in a for a patient that doesn't have any surgery, does no filter move?
No, no point. There's a bunch of reasons why patients move their heads. There is the null region or null zone. I have a complicated mathematical formula used to calculate this, but there is a primary position where the eye in the orbit, so the eye can rotate, say it can 360 degrees, say it could rotate completely. There's a position of the eye in the orbit where the nystagmus is least. And that stays pretty permanent most of a patient's life. Now, the patient can do other things with the eyes to make the nystagmus less too. They can converge, and that makes it less. So if they have to turn their head to look in the distance, they're not converging. As soon as they look near, they converge and the head posture goes away. They can also have a rhythmic changing intensity to their nystagmus. 17 to 33% of patients will have something called periodic or aperiodicity, where the nystagmus gets really intense, slows down. And those periods where it gets really intense, they have to turn their head in a different direction. So there's multiple reasons for a head posture, not all of which are due to a static eccentric null position. And the way we know that is, I'm not guessing at this, I examined the patients, looked at their recordings and go, wow, their head's straight when they do this, and so that's how we figured all that out.
So at a year, my daughter's resistance had a slight turn until less than about 3 months. Instead of doing it.
Yeah, I don't know why she doesn't do it anymore. Again, my best guess is that they choose not to use it. Yeah, even that early. Yeah, they're just, even a little kid is not going to want to be in pain, right? Yeah. Or sometimes a lot of patients will use the head posture to capture something and then stop. So they'll go like this and then stop. And then go like, oh, I want to see it, and that's it. They'll capture it. Yeah. Yes. Okay, Connor.
Just for anybody that wants to do more on Dr. Hertle, I've had 3 eye muscle surgeries from the youngest at 2 years old. And I've had a serious dramatic decrease in my nystagmus and my head turn especially. My head turn was very severe when I was little. I used to look at people like this when I was very, very young. And as I grew up and had my surgeries, my head turn is a lot straighter now. It still isn't, people still move my head straight, especially when I get pictures taken. People will go like, your head is straight. I'm like, it is straight. And I'm like, that's not straight.
Yeah.
But it is. It doesn't feel like it, but it is. I've gone from a very high acuity, I don't know what it was when I was little, but down to about 20, 25 in my last test from 3 eye muscle surgeries from Dr.
It's more than that. It was development. I'm telling you, all we do is take a little bend in the road. Most of this, the brain gets better. If you can move the system a little bit at an early age, things get better. Things get better. It really is just about doing the best you can for the developing brain. Yes, sir.
What is the age of the youngest child that you've operated on?
Well, I see patients from 26 weeks of age who are premature to 95 years of age. For nystagmus, the youngest patient I've operated on is in the first year of life, and I'll operate in the first year of life when they have an associated severe strabismus with it, because that has to be treated early. So a little child who has nystagmus and a large angle strabismus, who's an infant or a young child, I'll operate. Also, there are many children who have really severe tonic up gaze, tonic down gaze, and they're like this with big upbeat nystagmus from optic nerve hypoplasia, and I like to give them much more control of their visual system by operating them in infancy too. So I'll go down as young as 3, 4, 5, 6 months of age if they have another reason besides the nystagmus to operate. But in general, I like them to be on their feet. 10 to 14 months of age.
Yeah, we're going to have to stop you there. We got to
Okay. Okay. I'll stick around a little bit if you want to grab me.
Thank you, Dr.